Can you bring my slide? Thank you, the organized committee, Abdullah, Musa, and Fawaz, and everybody for inviting me. Those are the faculty of the Ischemia Club teaching for the Egyptian Board of Interventional Cardiology. You may even see your face among them. So I will show some cases. That's what, when you hear that somebody had coronary angio and was uneventful, he has patent stent, he has typical angina, and then he arrests after the angio by few minutes, and then you have to work on him to revive him, and then you discover that he had ostial lesion that was missed because the catheter crossed the ostium. So the ostial lesions are always tricky, and as well as he has here a dissection, and so you have to work on this. And so be careful. With normal angio, it may not be very normal. So we did the stent, and the patient was revived. So my message is always respect the clinical sense, the symptoms of the patient. While this is a true ostial lesion, she had angio few days earlier. She came. We planned to do imaging guided intervention. However, as soon as the catheter just touched the ostium, she passed into severe hypotension, and so we moved quickly and we covered the ostium. We covered the whole thing, the left main ostial LAD, and we did flaring, and the patient was revived. Always remember to do POT, and sometimes if we had time, we could have crossed the circumflex also and open the stent. This is another patient, typical wrist angina, severe, 35 years old. While discussing what to do with this left main lesion and giving some nitrates, you find out that the lesion had gone, and so some of the lesions are spastic, and some are lesions plus spastic. These are typical acute MI patients, LAD totally occluded. Technically easy to do, but the background is that she's 32 years old and she's 2 weeks postpartum. So why? There is no risk factors, but this may be an alarm that we are having epidemic of ischemia in the young age. She was not difficult to do, but we were alarmed by the age, and it's typically postpartum. And it's not, maybe it could be dissection, of course. This is an example of the multi culprits: acute inferior infarction, ulcerated LAD, severe lesion of the circumflex. Typically, the right we start with. While engaging the right and dilatation, he had short episode of VF, revived, and then stenting the whole artery, the whole right. And then this will go with the lecture of my friend Tariq Helmi, what to do with the other vessels. He is not in shock. And there is a thrombus also in the ramus, and so after fixing the right, we did the ramus, but we staged the LAD and circumflex because they need a lot of work. This is the idea: if you do multi-vessel intervention, do acute infarction, don't make it very complex. Do the lesions that are amenable, and if you have left main or CTO, don't do it in the same session. This is a continuation of what he mentioned in his lecture. So luckily, the lesion of the ramus was not in the left main, and so we could skip that one. This is the phenomenon. This patient is 72 years, typical chest pain, stress test completely negative after 8 minutes, and so this is the notion of stress test negative today and MI tomorrow, because after 2 days he had acute STEMI, and we had to fix the whole thing. So don't rely very much on non-invasive tests. If the patient is saying he's having typical chest pain, I don't send those patients usually for stress test. Maybe you can do CT angio, or if he is having high risk, then you go for angio immediately. You cannot be assured just by having a negative stress test. We cannot explain why this happened, but we see it very frequent. So this is an interesting patient. He had this angio 2 years ago. He's working in Libya. He's Egyptian, referred to Tunis. They did angio. He had 3 vessel total occlusion. How come that he's living? So they advised him for immediate surgery, but he escaped from surgery. He had total RCA, total LAD, and distal total CX, and he's having collaterals from the proximal CX going to the right coronary that supplies the LAD and supplies the rest of the right coronary, so he's living only on the proximal CX. Now he presented to us after 2 years with 2 things, with angina, typical angina, and as well as hyperinfroma, and so they need to operate on him as soon as so we planned to do limited revascularization. We thought of drug balloons. However, when you are fixing the coronaries, maybe it is not as easy as you imagine, and so we had to do something. We thought of opening this CTO of the LAD, which is not very difficult, with the use of microcath and Gaia, and then fixing the circumflex, and then postponing the right coronary. So in some, and then working with the surgeons, they need to do surgery for the hyperinfroma within a month. And so how come that this patient escaped, and how come that he's living on that? But we were able to open the LAD and also the distal CTO of the circumflex. We did that 6 weeks ago, and now he's ready to have a surgery. Maybe we'll do the staging and maybe shifting to the antiplatelets. He is now only on Plavix, and maybe we will proceed for the other procedure. Technical issues are not the most challenging, but clinical decisions are very important. This is the LAD after recanalization. And then we had to stent. Unfortunately, we couldn't put drug balloons. My friend Abdullah Shab, of course, would like to put drug balloons, but in this patient, we were not able. This was not safe because it was ulcerated and very ugly. So we stented the whole LAD by 2 stents and the circumflex. This is a patient, he had this angio, and he decided that he will do surgery. Multi-vessel, multi-lesions, but during the night, he had acute STEMI. So he came to the Heart Institute. We did a day crush for this LAD circumflex and left main. And he had also a very bad right. So this was done. It will not take long time, but it was, ejection fraction was 25. I am sure maybe discussion with surgeons, even he didn't have, if he didn't have the STEMI, maybe they will not accept him because of poor ejection fraction, or he needs a special center. So we did the left sync, and then we brought him after a week to do the right and to have a look at the left system. It was still patent, but he needed another stent in the LAD. Ejection fraction improved by that time to almost 35 to 40. So we stented that. But the problem was the right coronary. Again, back to ostial lesions. Sometimes it is hidden. Sometimes you need imaging, and sometimes it's very tricky where to start and where to end in these ostial lesions. It was like that. And so,
sorry, Dr. Ahmed, your time is up. I don't know if you can go up to conclusion of all.
Can I have only 1 minute or 30 seconds?
Okay, 30 seconds will be fine. Thank
yes. So this is a very interesting case to show. 10 years old, Pentel operation done by Italian surgeons, Heart Institute. The moment they try to close the chest, he's having collapse. So the Italian surgeon knows that this is coronary problem. And so we stented that coronary, and they were able to correct the whole condition. and the patient revived and was discharged after a few days. So they knew sometimes with reimplantation, it causes this. This is the last one. It is a paravalvular leak few weeks after aortic valve surgery, and it was closed by the multifunctional plug guided by the TE. Thank you very much.